on Dr. Shirish THORAT. He is going to speak to us about the subluxated cataract. Dr. Shirish THORAT is from Akola. Very good phaco surgeon. When I say very good means he is very good phaco surgeon. And now in this year he is a president of Maharashtra Ophthalmic Association. Yes, Shirish, go ahead.
Sorry. Can you help me?
कुठला
Sir?
लोडेड आहे ना तुझा हे कुठं आहे हां ना हां ठीक आहे ओके 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 IT person please help हां good
Good morning, all. At the outset, let me thank Dr. Ragini Madam for including me in the team. Friends, today cataract surgery is like refractive surgery.
light reduced by okay.
And what are the types of cataracts? Whether it is posterior polar, subluxated, patient want your 100%. So cataract surgery in subluxated cataract poses many challenges, right from getting a proper rhexis to the long-term stability of the IOL. Broadly, we can divide subluxation into three categories like mild, moderate and severe. Mild can be get tackled with the 3-piece IOL plus CTR. Moderate, which is below 120 degree, must need CTR plus 3-piece IOL, and severe cases of subluxation must need scleral fixation device. So this slide is important. If the zonular weakness is static, like in traumatic, congenital or colubomatous cataract, fix the back, and if it is progressive, you need to fix the IOL, like in a cases of pseudo exfoliation. These are the different devices used for scleral fixations. There are many more. So we'll directly jump to the case-based presentation. This is a case 1 with a coloboma more than 90 degree of subluxation. These are my planning. The rhexis in such cases is very difficult task. Always start the rhexis away from the area of zonal dialysis, that is exactly 180 degree from away from the dialysis. Go slowly in the area of the zonular weakness and purposefully decenter it toward the strong zonules, so that when you pull the back into the center, it will get good rhexis in the center. Capsular hook is the main device in such situation, and this is life saving. Slow motion phaco is indicated in all such cases. I usually prefer direct chop technique, and while removing the cortex, pull is toward the area of the zonal dialysis, that is toward the red glow. So epinucleus and cortex is getting removed. I have removed the capsular hooks. If any vitreous strands, if you are suspecting, then you can tackle at this point also. CTR is getting injected. Important is take out all forces of CTR on the Sinski's hook or any blunt instrument from the side port, or you can use the injector. I was suspecting some vitreous strands in the lower quadrant, so I am just confirming with the triamcinolone and getting it cut by the vitrector. Once it is done, I feel that bag is very much stabilized. Rhexis was small, so I wanted to enlarge the rhexis. Be cautious in such cases. Now look at the force. You should be very slow, and I am literally pulling the capsule onto the opposite side to get it propagated in the right direction. So this way the capsule rhexis is being enlarged and 3-piece IOL is injected and case is completed. This second case of mine, it is a colubomatous case, a congenital cataract, more than 180 degree of subluxation. So rhexis principle being the same. In this case, I wanted to use RC anchor, which is uniplanar scleral fixation device, having a large limb and a short limb and holes on both sides. Make the scleral groove in the center of the subluxation, make the scleral pocket to fix the capsule tension segments, And with the help of railroading technique, this IC anchor is getting inside. Care should be taken that it should not poke the capsule nor it should touch the iris, because these are very long needles. So IC anchor is getting inside, so it is very easy to handle, going to 2.8 to 3 millimeter of incisions. So long limbs to be placed into the bag, short limbs on the anterior capsule, and you can see how nicely bag is getting pulled and getting stabilized. And this of the surgery, as cataract is very soft, is like routine surgery. Only eye was suffice in this case, and again IOL is injected and case is closed. This is third case. The case is same, only approach was different. The fixation was with the Sioni's ring. Gore-Tex suture is fixing the Sioni ring. Only single suture was taken. With the help of railroading technique, it is taken out at the middle of the pocket and bag is getting fixed. This is fourth case where there is a more than 180 degree of subluxation. It is traumatic cataract. I approach this case slightly differently. Only mistake I have done, I have not plugged this area before the starting the case with the higher grade of viscoelastics. So confirming the vitreous inside into the AC, vitrectomy is getting done. Again, principle of rexis is the same. Small rexis is done. Later on, I have increased that rexis. So scleral, capsular hook is a mainstem. I wanted to use the Gupta segment intraoperatively to fix the bag temporarily in this case. I used iris hook to get it done, and intraoperatively I have fixed this bag with the Gupta segments. Lensectomy with vitrector done, as rexis was very small. Now rexis is enlarged and soft cataract is getting removed by the phacoemulsification. Actually, we can take out this Gupta segment, prefix it with the needle, but as things were going in right direction, I wanted to use the same ring inside. So loaded on the 26 number needle, 90 polypropylene sutures are taken out in the middle of the scleral wound, and bag is getting fixed, and 3-piece IOL is injected. This case number 5 showing some complications. This is again a traumatic cataract around 180 degree of subluxation, confirmation of the vitreous with the tricot, vitrectomy is getting done, slow motion phaco, capsular support with the capsular hook. You can see the prolarized bag, trying to stabilize it with the help of CTR, but not succeeded in getting support fully. So I wanted to use a Gupta segment again. These are really long needle, and these are very difficult to take it out from nasal side particularly. You can watch now. These needle are not flexible. It's very difficult to get it out because of nasal bridge. Now watch this moment. The trailing end of the needle has poked the posterior capsule. Now CTR is in, posterior capsule is ruptured, and capsular MS segment is inside, and vitreous is out. Still I went ahead with the vitrectomy. Vitrectomy is done, and luckily bag got stabilized. So 3-piece IOL is injected and case is completed. This is completion of surgery. So what precaution we should do in such cases? We just support this needle with the help of blunt instrument like this. So needle is getting in, and you just support this needle with the help of any blunt instrument through the side port. And you can take out this needle very easily to avoid the complications. This is another case. In this case, Hoffman pocket is being created. Again, the needle were used to guide the CT segments. So friends, to summarize, always start the rexis away from the area of luxation. Leading edge of any fixation devices to go towards the area of dialysis. Implant CTR as late as you can, but as early as you must. Scleral glue or Hoffman's pocket to be taken at the center of the subluxation, and always keep all the necessary devices ready in the OT and use the right device at the right time. Thank you.
Thank you, Dr. Shirish THORAT. That was a wonderful video presentation of multiple cases of subluxated cataract. What you showed us is that, in today's day, there is no need to avoid phacoemulsification in these type of patients. They should also get the benefit of phaco, and also an easy way to do it so patiently, so nicely. The most important tip that he has given is that we should have all the segments, the hooks, the rings in our OT ready at any given time to deal with subluxated cataracts. Thank you for the wonderful videos and the wonderful tips.
Yes.
Anybody else would like to say anything or add? Thank you, Shirish. Thank you so much.